Yeah, Seattle is a wonderful city when it doesn't rain, and we expect it this time of year, but the hospitality certainly makes up for more than that. I've kind of got a funny topic because I get to talk about everything and nothing at the same time. In 20 minutes, I'm just going to talk about general trends, and I'll probably draw a little bit from each of the talks you're going to hear after this. But I just want to try and kind of give a 30,000-foot view, and maybe by the end of this, leave you with some things to think about and hopefully get a sense of at least where I think we're headed over the next 10 to 15 years. I have no disclosures, except everything you're about to hear is mostly opinion. But what I think I can break this down to or distill it into are a couple of main headings: the changing pattern of spinal cord injury demographics, the classification schemes that we've gone through and that we may be faced with in the future, how treatment has evolved and where that may be going, and then just briefly touch on future challenges. And we're going to try and do that all within 20 minutes. But let's think about demographics. And I want to acknowledge one of the people in the audience here who really has been a major contributor to this field. Bijan Arabi is here, and I'm going to draw from his paper, which really, I think, summarizes not only what's happening in the last 15 to 20 years, but we also know that this has been going on for the last 50 years as well. And Bijan nicely, very beautifully summarized this in the Journal of Neurotrauma in 2019, I believe it was, 2021, I'm sorry, with this paper that he co-authored with the people you see there. And if we look at age and what Bijan did, as you will know, the Baltimore Shock Trauma Database is one of the most extensive trauma databases in the world. And he looked at the cases that came in there from 2001 at the bottom of your screen over to 2018. And what they found, if you looked at age, is it's not surprising. I think we all know this. We've seen an increase in the mean age all the way up to 50 to 54 years of age. And if you even take that curve backwards before 2001, the age goes down. So this is a good snapshot of what's been happening over the past 50 years as far as the age of our spinal cord injured patients. And spinal cord injury is not the only reason we're here, but spinal cord injury is one of the main things that governments do track. They don't tend to track spinal trauma as per se. So spinal cord injury can actually be viewed as a surrogate for spine trauma because it's a subset, right? So just because this represents spinal cord injury, this also likely represents spine trauma as a whole. And I think that's reflected in my practice too. If we look at severity, you can see that incomplete spinal cord injuries are on the rise and complete spinal cord injuries are very clearly on the decline over this 20-year period. If we look at severity as far as Asia motor scores, again, no big surprise. We're seeing the same thing, that Asia motor scores are improving. So the mean Asia motor score is reflected by more incomplete injuries over this 20-year time period. The morphology of the injury, again, hopefully no surprise to you, but certainly I'm seeing every day in my practice a rising incidence of fracture dislocation and, a rising incidence of, and I've got these reversed. I'll apologize. I have to fix that. This should be no fracture dislocation is on the rise, and trauma with fracture dislocation is actually on the decline. So we're seeing more patients that have pre-existing stenosis in an older population. Mechanism, this reflects what we've just seen in the previous slides. Falls are on the rise. So this is low trauma, low velocity, low impact, spinal cord injury. Motor vehicle accidents are on the decline, or at least spinal cord injuries are from them, and sports as well. Perhaps we're better regulating these types of events. So that's pretty much the snapshot of demographics. An older population, less severe trauma, incomplete injuries, and low velocity impact. What about classification? Well, this is kind of a fun thing to look at, perhaps more for the more junior members of the audience, but there's quite an extensive history to the way we've talked about spine trauma within our own groups. And it started back in the 30s, particularly with thoracolumbar spine injuries. And one of the first classifications, some of you may know, was just a simple morphologic classification by Watson, which then Nicole added to that in the late 40s. And Nicole brought out the whole concept of a column injury, but Nicole defined it as two columns. And it was divided at the posterior vertebral body between an anterior column and posterior column. Holdsworth added his mark in the early 60s, and then Kelly and Whitesides in the late 60s. But it wasn't until the 70s and 80s when CT scan and MRI hit the scene that we really saw a big shift in the way injuries were classified on the basis of anatomy and proposed mechanism, when we could start to understand the forces involved. And that's when the three-column model came out, which is still used today, which takes the posterior third of the vertebral body and the PLL and incorporates it into that middle column. And that, of course, was the Denis system that he came out with, and Ferguson and Allen added to this after that. And it was based on a retrospective 412 cases, the Denis classification. They defined the three columns and the 5 types of fractures. And I didn't want to, some people get confused between Denis and then the McAfee. McAfee was very similar, again, based on a fixed number of patients, but he added a 6th classification, a stable burst. But the two systems are very similar. It was then in the mid-90s that Magarel came up with the AO scheme. And that was a review of 1,445 cases based on the direction of the injury force. He defined 3 main types, A, B, and C, with 53 different injury patterns. I don't think I need to review this for particularly the Swedish people here. But then we enter into this kind of a classification scheme, which, at least for neurosurgeons, I think becomes kind of a loyal order of the water buffalo secret code. It's a little difficult to carry around. And if I'm telling you you're looking at a C2.2.2, I'm going to look at you sideways and think, I'm not sure what you're talking about. And I do that to Jens all the time. So when you get together with a group of people, you know that this guy here this is all he thinks about. And if you look at Mayo Spine, you get a typical Whiskey Tango Foxtrot kind of idea. Iowa Spine says crazy Germans. Texas Spine is thinking about a separate set of numbers that aren't really football related. And I just don't know where to sit in on this. But what I would say is that for at least the more simple neurosurgeons, and I know there are some neurosurgeons that we're going to hear from, Jim Harrop's on the line here somewhere, but the TLEX classification came along after in about 2007 by Alex Vaccaro, orthopedic surgeon, who very brightly put this together. And I think for those of us that like to teach residents and teach fellows, the nice thing about it is that it uses words that mean something to us when they talk about it, and it also helps in decision management. So from an overview, I think TLEX is here to stay. The people that are members of the AO Society will no doubt continue to use AO classification, but for many of the rest of us, I think we're going to be comfortable for the next 10 or 20 years with the TLEX system. Cspine doesn't quite have as glorious of history. It didn't really start to get classified until the early 60s. With Holdsworth, and then Allen was adding in when the MRI became available. A fellow named Harris added some descriptions, and then White and Punjabi introduced the 2-column model, which many of you may still use. Anderson introduced a 4-column model, which is a little complicated, and I don't think has really caught on. And neither by the same way, neither has the SLIC system, which Alex took off from the TLEX system. It really hasn't caught on either. And if I look back, I think the reason for this, it's a good scale. It has all of the similar features of the TLEX system. But when you deal with cervical anatomy, we're also dealing with C0 to C2, which really doesn't fit into anything. So we are not stuck. I think we enjoy anatomical classification. We look at bony and ligamentous injuries. So for example, C0, occipital condyle fractures. C1 has a ring Jefferson fracture. C2, these are all anatomical names they're names that go along with anatomical diagnosis. Odontoid, hangman, lateral mass, they're ligamentous injuries. And all of these describe C0 to C2, the axial spine. And we do the same with subaxial injuries. Bony injuries to the vertebral body, compression burst, fracture dislocation, teardrop fractures have a certain meaning, lateral mass. I think that this system, the anatomical system in the cervical spine, the subaxial spine, is probably here to stay as well. Again, because it's words that communicate ideas that come directly to a vision that you can anticipate and do something with. So spinal cord injury classification is a whole nother issue. So we've talked about vertebral classifications for vertebral trauma, but spinal cord injury classification, most of you will be familiar with this, which is a very, very detailed way to analyze spinal cord injuries. It's the ASIA scoring system and the ASIA grade system. But I really think in the future, we're not going to see this. It's probably still going to be around for prospective randomized trials. But in my opinion, they're a dying breed. The money isn't here to do those. And what we're really faced with now is big data. And I think we're going to see why it's going to talk about this, but I think we're going to see a yes, no box for spinal cord injury, fracture dislocation, yes, no, injury level C6, and then motor complete, motor incomplete. I think it's going to, if we want to buy into big data, we're going to have to make it meaningful for us. And I think that this is the way we're going to do it, because nobody's going to, you can't have bedside nurses take a course in the ASIA exam and then enter that data into a computer and have it worthy of anything. Registry is even a bigger issue. Registry data, we can distill more granularly, but I still think we're going to abandon the ASIA scale and go for something very simple and a more simple scoring scale for that too. So Wyatt will speak to that a little later. Well, what about treatment? I wanted to just spend a minute talking about treatment. Acute spinal cord injury, the medical management, there have been several publications on that, but still in the background are the guidelines, and they're due to be rewritten. These were developed by the spine section of the AANS and CNS, and again, recognizing Bijad and the contributions he's made to that. But there are several chapters in there that go through different types of medical management. We're going to hear from Bijan about one of those in a minute. But really, the only level 1 evidence, the class 1 randomized trial evidence for spinal cord injury, pertains to DVT prophylaxis. And also, I have to say it, are the harmful effects of steroids for spinal cord injury. There is class 1 data to show that steroids are harmful, but no class 1 data to show that they're efficacious. This paper has come out since the guidelines and of course is a widely recognized and worthy paper of comment looking at the timing of surgery. This affects all of us. It's a prospective observational study looking at less than 24 hours and greater than 24 hours. It has some biases inherent in it, like all non-randomized trials do. Large number of patients, and this was the main take-home message, that you can see on this scale the percentage of patients that actually changed from baseline, improved 1 ASIA grade, 2 ASIA grades, or 3 ASIA grades, and early surgery is the black and gray surgery is the late. And you can see early surgery seems to benefit patients that have an improvement in 2 ASIA grades, whereas those that had late surgery, only 6% of them changed 2 grades. There is a problem with this, though, in that if you think about a dose response effect, why aren't we seeing that same trend in changing 1 ASIA grade? You'd think more patients would change 1 grade rather than 2. And that's, again, one of the problems of a non-randomized study. The other thing I want to take home here, and I'm going to hit this again in a minute, if we look this is all patients. If we look at just ASIA A patients only, here's the data rearranged for ASIA A patients only. And what you can see is that patients changing 1, 2, or 3 grades, now these curves are much more flat, and they really don't look different at all. They're not statistically different. People changing 2 grades, there's no statistical difference between early versus late surgery. And even in the changing 1 grade, there's even a trend for the late surgery to do better. So this is data that really does not argue for early decompression, at least in ASIA A patients. And I think that doesn't even start to account for the problem we face in all of our studies, multiple comparisons and selection biases. So I want to close off here just by having you think about this. This is a graph, and we're going to put on this axis the number of axons that are intact in the spinal cord. 0 axons intact, 100% of them intact. And we're going to put on this axis neurological function, where there's motor and sensory complete injury, no function at all. And then on the top, there's normal function. And you can imagine, and this has been shown in many basic science experiments, you can imagine a curve like this, right? Where there's a critical mass of axons that you need before you start to get function, Asia B, Asia C, Asia D. And then there's another mass after which you get redundancy and a ceiling effect, no improvement. And it really is, when we look at injury and we improve over time, perhaps 10%, let's say 10% of injured axons, then that's going to make a difference if the patient is starting out in this part of the curve where they're incomplete by definition. But if we're looking at Asia A patients who probably start out way over here, 10% of axons probably won't make a difference. And so that's what we're seeing in the studies. I think that's what Staskus shows. I think that's what the other studies have shown. And this is the kind of thing that we're up against. So this is one of my favorite pictures. This is Steve Glassman, was in on this paper as an author from Kentucky. And this shows if you compress a rat spinal cord and then leave 20% canal compromise, if you leave it in for 2 hours and then decompress, if you leave it in for 6 hours and decompress, 20% spacer, then take it out after 1 day or 3 days, all of us would want to have that spacer removed at time 0 or time 2. But remember, this is a model of incomplete spinal cord injury. This is not a model of complete spinal cord injury. And then the whole thing about central cord syndrome, we're going to hear about that. It breaks all the rules. Low velocity, low impact, no fracture, no dislocation, preferentially affects the hands. There's axial displacement, not transection or translation. There's no acute spinal cord compression. There's other factors at work. So we got a lot of work to do to get to the bottom of this and how best to treat it. And it probably involves Asia A to E as well. Future challenges, I only wanted to put this in. We're an easy target. If you look at, and I know this isn't just trauma, but if you look at costs of various surgeries in the United States as of 2019, here we are, number 3. And that does include trauma. And if you think healthcare is rationed now, come to Canada and they will start picking the big spenders and they will gradually squeeze them. So my advice is get involved in societies, get involved in the AO, get involved in research, become an advocate for your patient and for the profession. Otherwise, our future is not going to look great. And so I've tried to hit a little bit about spinal cord demographics, classification, treatment, future challenges. I want to thank this guy especially for doing the heavy lifting on the course. And with that, thank you again for your attention. Appreciate it.
Fantastic, John. Thank you so much. Really big picture. Where are we with actually having a spinal cord injury registry in North America, in the US or so? I know there are several things, but since the individual health existential crisis burden is so dramatic, the societal cost, the personal cost is dramatic. How are we now in terms of actually categorizing those? We have cancer registries, we have heart, cardiovascular. I still don't see a really easily accessible spinal cord database.
I couldn't agree more, Jens. And embarrassingly, kind of, Canada is about 15 years ahead of us on this. And they have a very extensive spinal cord injury database, and it's paid for and monitored by the Rick Hansen Society. So that's an option here, is to tag into our community partners and try and help fund. But I see a bigger opportunity with the ASR, the American Spine Registry. It's people like us who can get in there and help carve out a module for spinal cord injury and make it part of registries. It can't just be part of big data because it's not going to give us the data we want. I think we have to argue for a registry.
And something we'll talk about later, which is such a really big deal, and that is geriatric spine trauma. So you hit upon that in Bijan's legendary article, which we have presented here several times, can't be overstated in terms of its impact. But where do we fit those patients? And again, last night in our spinal trauma case presentations. We had 3 active cases, and actually you all helped me talk through one case, and so we rounded out her 6 this morning. But we have so many geriatric patients, and they're so commonly unrecognized. They've had myelopathy, they've had cord compression, then they fall, and then they're cord injury patients. So how do we heighten awareness of all medical specialties as to this? I call it an ongoing crisis, actually. I mean, our hospitals are full of these poor patients. What can we do?
Yeah, it's from the ground up. We've had to go to our ER department and say, anybody with tingling in their fingers after a fall, we want to see them, even though they may not have a fracture or dislocation. We have an 80-year-old woman, she falls and she says, my hand's numb, right? That's somebody we need to see and we need to get an MRI on. So it starts educating the ER doctors, but think about where the real spinal cord injuries go. And at least in Arizona, there's no rehab for these people. They are geriatric and they're abandoned. So it's awareness, Jens. I don't have a good answer.
Great. So thank you so much for your great presentation. Way to start off.